All right, so for today's video, we're going to be talking about PIVOMs, otherwise referred to as passive physiologic intervertebral motion testing. Now, before we even get started with our discussion, we need to acknowledge that the inter-rater reliability for this test is very poor. And so you may be asking yourself, and why in the world do we even learn these techniques if the inter-rater reliability is quite poor? Well, first and foremost, depending upon the study that you review, Cook and colleagues in 2014 or a recent systematic review that was published here in 2020, both acknowledge that while inter-rater reliability is not fantastic, intra-rater, so between that clinician, their initial assessment to a follow-up or secondary assessment, there may be evidence there to support its use. Additionally, other research has indicated that patients find it quite reassuring that a clinician would take the time to place their hands on them and be as specific as possible to where their pain is and even a level-by-level assessment. And so certainly there is what we might even call a non-specific effect that coincides with the use of PIVOM assessment. So we hold all of this in balance and tension as we learn these techniques, recognizing that they do not possess the guru level of amazement as we once thought, but also they're not complete rubbish, right? And so we find that they're balanced somewhere therein. And so as we do these, keep that in mind. Additionally, depending upon the size of your patient, you may also find that PIVOM assessment is challenging based on your relative size to the patient. So if you are bigger than your patient, or at least somewhat balanced to your patient, you may be okay. And you'll see why in just a moment. However, if your patient is significantly larger than you, your overall accuracy and ability to accomplish this test is likely to be rather poor. And so if you're looking at balancing your time and effectively using your time, you may wish to skip these tests in favor of something that will give you more clinical relevancy and accuracy. So let's go ahead and get started with the test. First and foremost, we need to expose the lower back. We'll do that in just a second. But even before that, we need to have our patient slide towards us on the table. They need to be all the way up close to us such that we're not having to reach out to try to palpate or feel what's going on. At this time, we're going to bring the patient's shirt up. And really, you don't need to do much. You just need enough to where you can expose the back. You do want to be on skin for these assessment techniques. And so from here, identify your landmarks. We can find the top of the iliac crest. That correlates to the interspinal space of L4-5, typically where we find our L4 spinous process. And that's important that we find that level. And then from there, we can use our fingers to work up at each interspinal level. Now, some clinicians will teach this such that you are on the spinous process itself. Other clinicians will teach that you are in the interspinous spaces. Myself, I prefer to be kind of in the interspinous space such that the spinous process would fall right in between my digits. So we're going to find that interspinous space at each level. And then from here, that is the physiologic intervertebral motion that we're going to be palpating as we move the patient through some different positions. All right? Now, the first position that we're going to assess is going to be flexion and extension. Okay? Now, for flexion and extension, if mass of the lower limb is a challenge, one way to do this is to just lift the top leg, right? And then from here, we're going to ask our patient to relax, and we would take him through flexion, and then we would take him through extension, right? Ideally, though, you really want to have control of both limbs. And so for this, we're going to bring our patient up. You essentially want your waistline to be right in line with their waistline such that they're up close and personal to you. They're not going to fall off the table, all right? That way you're kind of protecting them. And then from here, we're going to ask the patient to bend the knees. And then this is where you get to kind of get your workout in, because you're going to come around and lift the legs as a whole, right? And then you're going to take them into extension and then into flexion. Find that inner spinous space into extension and into flexion. Right? Now, as you do that, a couple things are going to happen. One, you're going to see this, right? This is the roll of the trunk, right? Now, that is a challenge in and of itself because the more that the patient rolls back and forth, the more it's going to distort your palpatory kind of specificity here, all right? Second of all, it is a physically tiresome event to be going back and forth into flexion and extension. And so as you begin to fatigue, that also is going to compromise kind of the specificity here, all right? So that's our flexion and our extension. Second, we need to look at side bending. Now for side bending, we're going to adopt a very similar position, but with side bending, we can only do one side at a time, which means we're going to look at this side first, and then we would need to have the patient roll to the opposite side. Same position here, we're going to grab here, find our inner spinous space, and then we're going to lift the patient up. So it looks like this, all right? Finally, we get to rotation. Now for rotation, we need the bottom leg to be straight, and the top leg is going to come in like this, all right? So at this position, we're going to continue to support the upper body by kind of angling here, all right? We're going to bring this lower leg back onto the table, hook that right there, and then from here, we can use this arm to kind of bring the upper trunk back, right? And use this arm to rotate the lower trunk. And so now we can use each individual hand to identify intersegmental rotation. So it would look like this. Okay? So it's an opposing roll. The top half comes towards the table as such. The lower half is going to go this direction. All right? So again, with your PIVOMs, recognize inter-rater reliability, very questionable. Intra-rater reliability may be better, but still we need to proceed with a degree of caution. So have a go with a peer or colleague, and let me know if there's any questions. Trying to roll off my table?